Pediatrics is my thing. I've been doing pediatrics almost my entire career. I blame Dr. Larry Webster, who is the founder of the ICPA, the International Chiropractic Pediatric Association, for steering me in this direction. He really kind of pushed me into going into pediatrics. And I think, honestly, if he was alive today, he would be very much in favor of using Activator with kids. Because everything he did was all about light adjusting, but nothing heavy-handed kind of stuff. So I think he'd be very much in favor of this. And my practice specialty is kids on the spectrum, number one, and babies, little babies with all kinds of developmental issues or colic reflux, nursing issues, those kind of things. So real little ones, or slightly older ones closer to like a year who are having trouble like learning how to walk or learning how to crawl or learning how to roll or those kind of things. And it's so gratifying because moms will come in to you and they will say, as an example, we just had a mom come in last week whose kid was having trouble kind of rolling and also having these tummy issues, and the kid's almost a year old. And the mom said, I've been telling my health providers what's going on, and are you going to actually pay attention to what I'm saying? Because everybody's blowing me off. Everybody's saying, don't worry about it. It's fine. He'll get it eventually. For the tummy things, just take these meds. And for the rolling thing, he's just, it'll get there. He's just a late bloomer, all that kind of stuff. And she said, do you feel that way? And the kid's, 7, 8 months old. No, I don't feel that way. To me, the only time there's a late bloomer is if a kid's like prematurely born. All right, you're going to have some delays for sure. But every child is almost like when you turn on a laptop, right? Do you guys still use laptops, or is it just iPads now? Right. So if you turn on a laptop, right, from totally off, right, what does it do? It boots up. And does it take like a certain amount of time to boot up if it's in good condition, right? So like I have a MacBook, so if it was totally off and I press it, then the first thing that happens is it goes ding, right, makes a little noise, and the apple comes on, right, with a little bite off it, right? And then the taskbar goes like this, and then my screen pops up. And that takes like maybe 10, 15, 20 seconds for it to turn on, right? And that happens every single time, so I know it's working good. But if tomorrow morning I turn on my MacBook and I press the button like this and it goes on and it goes ding like this, and then nothing happens. And then nothing happens, and then nothing happens. And I'm sitting there waiting and I'm like, this is kind of weird. And then maybe a minute goes by, and then the apple comes on, and then I'm like, okay. And then another minute comes by, and then the taskbar comes on, and then the screen comes on. It takes like 3 minutes to do that. What would I do? What would I think? Yeah, something ain't right? So I don't know about you guys, but if I have a MacBook, so I have Apple Care. So I'll call up Apple Care, and I'll say, hey, I know what's going on. It's a little slow. Maybe something happened, right? But in the health world, healthcare, we don't have a healthcare system in this country, but in the healthcare system in this country, it's a sickness in this country. So in the healthcare issue in this country, if there's milestones, they're supposed to be met on time. If they're not being met on time, something is wrong. And that's exactly what I said to this mom. I said, I agree. I said, we're going to find out what's wrong. We're going to figure this out. And by doing the exam that we do and the assessment that we're able to do and just taking an easy history, we know that there's something going on with this kiddo, and we're going to help this kid. Because and that's what happens after, like when you really get chiropractic in your being, you know it's going to work. I have no doubts. If they follow what I say to do, it's going to work. If they do it their own way, it won't. You want to come in once a month or whatever and don't do any exercise recommended, well, it's not going to work, so don't start. Right? Because I've had people say, well, can I just try? No, this isn't like a try. This isn't let's roll some dice. It's either we do it or we don't. You want this to work, it's going to be 4 to 6 months. That's the way it is. 4 to 6 months. There's no try. So that to me is the exciting thing. It's like when you've been doing this for so long, I can say with authority, because I've seen this a bazillion times, you guys can say, well, I'm just a student. I've never really seen it. But I want you to live through me. I want you to live vicariously through me. So when someone says, can chiropractic help with this? The answer is, of course. Now, do I treat colic? Do I treat reflux? Do I treat developmental delays? Do I treat autism? Do I treat those things? No, I don't treat a thing. There's only one thing that I take care of, and what's that? Subluxation. That's it, nothing else, right? So don't get caught up in when someone says, "Oh, so do you like take care? Do you fix autism?" No, I don't fix autism. I don't fix colic. I don't fix asthma. I don't even fix back pain. I work on subluxations. If there's a subluxation, I can work on that, and then the body will do whatever it needs to do from there. But that's a really important thing to understand, because you're not in the business to treat. You're in the business to take care of subluxations and then let the body do its own work. So what we're going to go over today is something that Dr. Ford, the founder of Activator, he said, it was a seminar, maybe I became advanced rated around 2008 or so. And around 2010, he was still doing seminars, and he happened to do a pediatric seminar for us here in Atlanta. So I'm going to show you these 4 steps that he said, especially for infants, God bless you, especially for infant adjusting. I know it's light colored, but I didn't have a darker colored pen. But I'm going to show you those 4 things because that's what he went over. And I've given you each baby dolls so that each one of you are going to practice. So some of you have activators. I've handed out some activators. And if you don't have an activator and you just want to practice along, don't use your finger. That is not a good substitute. But if you have a pen or a stylus or a Sharpie or a marker or something, you could use that if you don't have an activator. And by the way, all those babies are mine. So when we're done, you give them back to me. These aren't like things for you. Some people get confused. I've had people walk out with them. And I'm like, no, that's my baby. So it's the first. Yeah, go ahead. The first thing that we're going to do when we're looking at a kiddo, and this is a post-examination. We've already done the full examination, and now we're going to adjust. So the first thing Dr. Ford said is we're going to examine this infant's atlas. And the way we're going to do this is supine. Even though I know that you guys are taught atlas, prone when you're doing adult adjusting, in a smaller child, a kid who's like a toddler, 3 years old or so or below, you're going to adjust them supine. And why do you think that is? What was the reason that Dr. Ford gave us? Well, if you put the baby on a bench like this, first off, they won't sit this way, A. And B, if let's say you were, I would never go across like this, but let's say you're doing this. If I'm doing this, see how my hand is going up like this? So now instead of having an M line to drive, I'm now adding an A line of drive. And we don't want that. We want the straight lateral to medial. So, but their atlas is so far forward that if they're in a bench that has this head thing, then it doesn't work very well. So when you put them supine, now you can easily adjust like this, which we'll talk about in a second. So anyway, so the child is supine, and now we're going to look for a short leg. So everybody look for a short leg. And does your baby have a short leg? Yeah? Okay, good. So whatever short leg it is, I'm going to do left. So whatever short leg it is, I want you to tap the atlas on that short leg side. And what is that called in Activator? A pressure test. Right, we're doing a pressure test. So now the legs are balanced. And now I'm going to, so that shows me that we have a left atlas. This is a neurological test showing we have a left atlas. Now take the activator or your finger, or your stylus or whatever, and then take your finger, in this case, because it's a left atlas, I'm going to use my left index finger, and I'm going to put it over the atlas transverse process like this. And now I'm going to take my activator, I'm going to put it on my fingernail, not on my knuckle. On my fingernail. And your line of drive is straight medial, so it should look like this. So if you're doing this or whatever, that's not right. I want you to put it down so that it's going straight lateral to medial like this. And it's ideal if you take the baby and make the baby in this direction with you. So like Shelby, kind of turn the baby so the feet are towards you. Yeah. So it's straight like this. And you don't want to cross over. I see some of you guys are doing this sort of a thing, right? You don't want to cross over. You want to keep it straight like this. Okay? And then you thrust lateral to medial. One thrust. And if you're using an activator 2 like this one, you put it on one ring. So like this was on 4. So you put it on a one ring like this. If you're using an activator 4 like some of you guys have, it'll be on a setting 1. And an activator 5 will be a setting 1 also. And then it'll be one thrust through your fingernail. Please make sure you don't do it on your knuckle, because eventually that's going to not feel very good. But if you do it on your fingernail, I've been doing this for years and years and years and never had any repercussions from it. So make sure you're doing it over your fingernail. So we do one thrust, and then we recheck the legs. Pretty easy, right? Got it? Good. So now, let's turn Junior over. And now we're going to do sacrum, an AI sacrum. So, what quarter are you guys in mostly?
8th, 7th.
8th, 7th. I know you're first, right? But so, have you guys had? Do you know the Logan contact is? Do you know what that is? Who knows what the Logan adjustment is? Oh my. Okay. All right. So, all right. So Logan is a chiropractic school in St. Louis. That actually, Dr. Four has a brand new research facility there, which is kind of cool. But anyway, it's one of the oldest chiropractic schools in the country, next to Palmer and Cleveland. And the Logan adjustment was something that came about sort of to work on the sacral area. So B.J. Palmer, back in 1910, he invented HIO, which is adjusting the upper cervical. So Doctors Hugh and Vinton Logan, who were both Palmer grads, wanted to do something a little different. So instead of adjusting the atlas, you'd adjust the sacrum. And that was their big thing. And when you guys take special pops, or you take teach the advanced pediatric technique class elective, which you should all take if you're interested in kids, because I will teach you 11 different adjusting techniques to work with kids, aside from an activator. But the way that the Logan adjustment works is you're going to work on the sacrotuberous ligament. Do you know where to find the sacrotuberous ligament?
We should all know where to find the sacrotuberous ligament from our PI contact for adjusting a PI with activator. When we're pressure testing, that's sacrotuberous ligament.
So in a little baby, it's a little different than the way, but you're absolutely right, we should all know. In a little baby, the best way to find the sacrotuberous ligament is to bisect the coccyx and ischial tube. That's the best way to find it. So you got coccyx here, ischial tube here, so right in between there is the sacrotuberous ligament. Because with a little baby or a child on the spectrum or something, much harder for you to ask them to participate in finding it. So you're going to find that sacrotuberous ligament is going to be on one side or the other. Now, which one are we going to adjust? So there's two ways to determine which way we're going to adjust it. One way is we're going to squeeze the glutes like this at the same time as we look at the top of the glute crease. And if the glute crease goes to the right, then what do we have? We have an AI sacrum on that side. So if the glute crease goes to the right-hand side of the infant, then we have an AIR. If it goes to the left-hand side, then we have an AIL. That's one way to determine which side. Another way, which I really like, where you don't have to look at the glute crease, is you just take two fingers like this and put them on next to S2 on both sides. And then you're going to palpate, and you're going to do like a motion palpation. You're going to push on the left side, push on the right side, push on the left side, and push on the right side. If you have an AI sacrum on one side, what's that going to do when you push? So if I push over here versus pushing over here, what's going to be the difference?
One's going to feel anterior compared to the other pushing back.
Right, so the posterior is going to feel harder or firmer, where the anterior side, as Webster used to call it, he said it's going to be boggy or mushy. So if we're going to adjust the anterior side, then we're going to go on the mushier side. So that's how you determine it. You're pushing here, and on the anterior side, it's going to feel boggy or mushy because it's further down, right? The sacrum has nutated this way, so it's further down. So let's say it's an AIR, because you felt it mushy on that side. Take your finger, put it on the sacrotuberous ligament on that right-hand side. Take your activator and put the fingertip on, the activator tip on your fingernail like this, but then drop your hand all the way down so it's on the bench like this, because the line of drive is PSL. You're going upwards, so this is what you want it to look like. Okay? Once again, setting 1 or a number 1 if it's an activator 4. 1 thrust, click over your fingernail, and then either recheck the glutes or repalpate. All right? Questions? Yes?
Do you often find Atlas on the OPD side?
I can't say I find a correlation like that.
Okay.
Although I will tell you, just from experience, there are way more left atlases than there are right atlases.
Okay.
And that being said, for those of you who have been in clinic and stuff, what is a far more common PD leg? Right side.
Mm-hmm.
Like almost universal. There's like 85-90% of people have a right short leg, for those of you who don't PD, or right PD leg. So why do you think that is? Let's talk about brains. So why do you think we have most people having a left atlas or a right short leg?
Having to do with handedness, like being kind of really like right-handed.
Yeah, so if we're right-handed, what's that going to do?
So you like use the side more, it gets tighter, and you kind of like torsions the pelvis, so that becomes the shorter side. Kind of.
That's a possibility, is how everything's torsion. But what do you think? What's your name? Maddie. So what do you think brain-wise? Think of brain-wise. So if we're mostly right-handed.
I don't know, I was thinking like maybe you're more like cognizant of that side, so you're like recruiting a lot more on that side.
Okay.
So because left brain, left atlas crosses over to right.
There you go. Very good. So we have left brain, left atlas, cerebellum, and then right rest of the body, right? So that's why we see a lot of this. And you think about it, most people are what? Right-handed, right? So it kind of makes sense. And the handedness, even though it does not come out until the kid's between like 3 to 6 years old, is kind of built in. If you look at the studies of brain laterality, that laterality is kind of built in. Interesting factoid, though. Kids with autism. So if we have about 85% of the world is right-handed, what is the percentage of kids who are right-handed with autism? Less than 50%. That's interesting. So what that shows is their brains are not, like our brains are supposed to be asymmetric on purpose, right? We have asymmetry in our brains to allow us to perform a lot of different functions. Especially the more significantly impaired children on the spectrum, they are more likely to either have neither dominant or be left dominant instead of right dominant. So it's quite interesting seeing what's going on with these kiddos. Anyway, so that's a segment. Any other questions? All right, good. So let's talk about 2 more things, and then we're going to do like a breakout workshop kind of thing. So normally, when we're looking at the pelvis, in a older child or adult, you're doing the whole leg check, kind of thing like this. Because you're looking for possibility 1, possibility 2, possibility 3. But we're not going to do that in a baby because, especially, or a kid on the spectrum, because to do this sort of thing is going to almost impossible to get them to cooperate. A lot of kids on the spectrum, especially, you try to have them do a dare-filled leg check like this, and they're just going to lift their whole legs up, like you're lifting their body up like this. So doing a leg check with a lot of those kids is just not happening. So what Dr. Force said is we're just going to sweep. So if you remember how we would sweep, right, after we're finding which possibility is, we're just going to sweep. So if we have the child is prone like this, and then we're going to look at the long leg side or the OPD side, and we're going to sweep from above the PSS down like this. Above the PSS and down like this. And if that balances the legs, then we have an AS ilium on the long leg or OPD side. Okay? And what Dr. Force said is instead of adjusting all 3 of the areas, the sacral base and all that kind of stuff, you're just going to adjust the ischial tube, just the third piece. So adjust the ischial tube. And the line of drive will be anterior, inferior like this. So you're going down towards the kid's toes, like this. But putting your fingernail right on the ischial tube, like this to dampen. That's what he used to call. That's what he calls this, dampen the force, like that. 1 thrust on a setting 1, and then recheck the legs. And then the last thing that we're going to check is for the PI ilium. And the PI ilium, normally you're going to push into the sacrotuberous ligament like this, but Dr. Force said with babies, because they have a diaper on and stuff, it's hard to check. You don't want to pull the diaper down again. So he said just go from right below the PSS to above it, like this. Right below the PSS to above it. And if that balances the legs, then you have a PI ilium on the PD side, or short leg side. And, hey.
Thank you.
Welcome. So in that case, now we're not doing all 3 of the areas. We're only going to do the 3rd area. So we're going to take our finger and put it on the iliac fossa, the last of the 3 areas. We're going to put our activator on our fingernail like this. And now the line of drive is AS, anterior superior. 1 thrust, setting 1, click. And then we recheck the legs. All right? Any questions? Yes?
I have a quick question. It's about the AI sacrum. Do you ever check for the glute crease and then you also motion palpate and get conflicting results?
That's a great question, Shelby, and the answer is no. Webster really came up with a great way to find things. And Dr. Ford is really borrowing a lot of Webster's stuff here. So I've never had a conflict. If the glute crease goes to the right, then I'm going to feel it motion palpate to the right hand side. Yeah. Good question. Any other questions? All right, good. So you have a question, Bill?
Yeah, I was just going to ask why these are the most common things that you find in a baby and why, and if you check anything else.
Yeah, good question. So Webster was my teacher, like I said, and Webster would always say, in the beginning, when you are first working with an infant or a child with some special issues like autism or something like that, top and bottom is where you're going to check. Top and bottom. So top and bottom means what? Nerve system-wise. Parasympathetic. Right. So we're going to check atlas as a major thing for the top, and then we're going to check sacrum and PI and AS ilium as the major things on the bottom. So in the beginning of care, when I'm working with any child, this is where I'm starting. I'm not working on everything else, because Webster used to say, if the kid is and like most kids are stuck in sympathetics. And how do you know they're stuck in sympathetics? Give me symptoms to say a kid is stuck in sympathetics.
Crying 24/7.
Crying a lot, colic, constipation, diarrhea, right?
Latching.
Right, not latching. So what are the three things that a baby is supposed to do? Eat, poop, and sleep. What three things are controlled by parasympathetics? Eat, poop, and sleep. So when a mom comes in and says, my kid is having trouble eating and pooping and sleeping, or any of those things, any combination thereof, they're stuck in sympathetics. So you got to turn on their parasympathetics. So that's why he said, Webster said this, and then Dr. Ford, borrowing Webster's, because Webster was actually a Logan graduate, so borrowing Webster's concepts, said stick with this. So I've been doing this for years, and Webster was right. Any other questions? All right, good. So what I want you guys to do now is I want you to practice all four of these movements on the baby doll, and then I'll go around and answer any questions. All right?
Thank you so much.
All right. So we had a lot of really good questions, so I want to clear things up. Number one, Dr. Ford said that this is not done on newborns. So if we're going to do this, this is going to be for mostly kids 3 months old and older. So we will not do these kind of things, use the activator. Not that you can't, or you shouldn't, but he said it's probably better to do sustained contact, which you guys will learn in Special Pops, and we'll go over in great detail in the advanced technique elective. So that's number one. So this is only for 3 months old and up. Number two, where is the baby? JC asked a very good question. Where is the baby in all this, and like how do you position yourself? And the answer is that you're going around the baby. So you're not turning the baby like this, wherever it needs to be. You're going to go around the baby, and basically what usually happens in my office is that the mom or dad or caregiver are sitting on the bench, and these obviously are not easy to do that with, but and then the baby is either face down like this on mom or dad's lap, with their chin on the side of their thigh, so you know that they're not pushing their nose into the thigh like this. And this is, once again, 3 months old or older, right? So we're not doing this on a baby who's 2 weeks old or something like this. Or the mom can lie face up, and the baby lies on her chest or the dad's chest or whatever, like this. Those are the two best ways to do these sorts of adjustments. Is the baby is prone or supine and lying on mom or dad's lap like this for the prone adjustments, or lying on if mom or dad is lying down, or if they're supine, you could put them on the bench like this, with mom or dad holding them and looking at them as you're doing whatever work you have to do. So that's an important thing. So to answer the question is you're working around the baby. You're not turning the baby and doing that kind of stuff. You're working and moving your body in whatever position needs to be put in. And then the last thing is in terms of like the different lines of drive, especially with the sacrum. The reason it's PSL is because you're going upwards like this versus downwards like this. The question came, can you adjust the posterior sacrum on this side? And the answer is yeah, but we're choosing the anterior sacrum on purpose because that's the Logan adjustment, and the Logan is a better parasympathetic adjustment, and the Logan contact is the sacrotuberous ligament. Can you adjust the posterior sacrum? Sure. Then you'd adjust the side that's firmer versus the side that's boggier. And something that's also really important too is when you are doing these adjustments, one thing that Webster taught us is that you don't have to adjust everything you find on every visit. You should adjust, especially in the beginning. Once you know someone and you've seen them for a while, adjust whatever you want, whatever you find, and whatever is validly indicated. But before that, in the first several visits, when you're adjusting an infant or newborn or even an adult, I only adjust what is absolutely necessary because I want to see how the body responds. Because let's say, as an example, even with an adult, you have adult in clinic with back pain, and you adjust a PI ilium and an L5 and an L3 and a T10 and a T4 and a T1 and a C5 and a C2 and a C1 and an occiput, and they come back the next time and they say they're better or they say they're worse. What worked? So I would rather say, okay, I'm going to adjust PI ilium, I'll adjust sacrum, I'll adjust maybe one thoracic, I'll adjust one cervical, and let's see what happens. So you do 3 or 4 adjustments in the beginning, mostly sticking with top and bottom, and with an adult especially, and see how they respond. Because if they say they're better or they're worse, then you know something that you just did either was helpful or wasn't helpful. But if you do 10 different things, what do you pull out? What do you switch, right? So it's actually a much better way for you to... Now, in clinic, you may just have to do what they tell you to do, which is fine. I'm just talking about the real world versus clinic. Any other questions about anything else? All right, great. Well, thank you guys, and I appreciate your attention. And give me my babies back.